Okay. Very good evening to you all doctors across the globe. I am Saravanan from Team BSP. On behalf of the entire organization, the team who had put this program for all of us, I would like to welcome you all for this Sepsis Symposia, titled as United for Better Outcomes. The topic of this program today is Optimizing Outcomes in Sepsis, the synergy of antimicrobials and immunomodulators. Professor Lee from Korea had Grace will be talking to us, will be presenting to us the entire presentation. We also have across the countries in Tanzania, Uganda, Kenya, Nigeria, and Zambia, our moderators, along with the entire audience over there in all these countries have joined us. Once again, we welcome you all doctors in these countries and across the globe. They are also joining from their respective clinics, offices, and their residences for this symposia. We are very happy to host you all. It's a sheer honor on behalf of Team BSP to invite you all once again. And before I give the handle to my in-house medical, Dr. Savio, I just wanted to quickly walk you through the corporate BSP, what we stand for. We always say that we stand for bringing life to life. If I have to tell why we stand for bringing life to life, there are 3 or 4 important reasons I would like to quickly walk you through the corporate story. We are driven by people and science. More than 2,500 plus employees we deploy across the globe who work tirelessly to give those world-class products. And that's why we had product patent of 15 plus products across India, US, and European Union. 60 plus countries works round the clock to bring us the best of the class products for your patients and their well-being. 13 plus market leading products in all our therapy that we operate. And we have been constantly achieving awards for innovation and excellence. That's what Team BSV is for. And we are primarily present in 3 focus areas. And we are in fact leaders in these 3 focus areas: the women's health, the assisted reproductive technology, and your own therapy, critical care and emergency medicine. We are leaders in these therapeutic areas. And how we do this in terms of our leadership, we build research-driven products on differentiated tech platforms, be it in terms of recombinant technology or offering niche biologics, complex delivery and formulations, and immunoglobulins. So these are all 3 major research-driven products on the differentiated tech platforms. And we bring key scientific breakthroughs that are first of their kind. BSV has pioneered many first in complex pharmaceutical segments. The research remains the strongest pillar in our journey towards providing world-class treatments to millions of patients across the globe. And our recombinant FSH, our anti-D immunoglobulin, and recombinant HUCOG, or some of these products, I can just give you as an example that we bring those key scientific breakthroughs that are first of their kind. And how we do this, we make high quality products at our world-class facilities. One in India, located near Mumbai, with 5 dedicated injectable formulation lines and 2 API manufacturing lines, which produces cutting-edge injectables for India and across the globe. We also have another plant in Aachen, Germany, US FDA approved plant, manufacturing plant for APAs and fertility hormones, which is focused on different R&D activities, continuously pursuing manufacturing of products of highest quality, purity, and stability. And that's the reason why I say we bring life to life. We stand for bringing life to life. And with all your continued patronage, encouragement, ideas, guidance, we make sure that the patients are well taken care of through our research and innovation. We are glad to host you this webinar, and I would like to thank the entire team of BSV over here to put up this show, all our managers, the head office folks, the medical team, and everyone who are present here. May I now request Dr. Savio to take over, introduce our speaker for this evening to the larger audience, and walk us through few do's and don'ts in terms of how to go about this program. Thank you.
Thank you, Saravanan. I have the great privilege of welcoming and introducing our speaker, Professor Kang Hyun Lee, who is from South Korea. Professor Lee is the Professor for Emergency Medicine from Yonsei University from Wonju College of Medicine, South Korea. He is the current president for the Korean Society of Disaster Medicine and the Associate Editor for Clinical and Experimental Emergency Medicine from 2023 till the present. He has held many key leadership roles in very prestigious global as well as national and international societies in emergency as well as traumatology. With 282 research papers peer-reviewed in his name, he is authored and co-authored 14 books in emergency medicine, trauma care, and disaster response. A voracious speaker, he has numerous keynotes and plenary speeches at international conferences on emergency medicine, critical care, and traumatology. In addition to that, I think what stands out for Dr. Lee is that he's a very strong visionary who has strengthened South Korea as well as the global presence, especially in Tanzania, Uganda, Uzbek. I think he was there in the African continent last week itself in trauma care, emergency medicine, disaster medicine, setting up medical associations, and he is even involved in the latest tech with computer simulations and AI-based solution development. He is also very strongly involved in academic progress in international domains outside of Korea, and he's currently researching airbags to protect the rear-facing passengers in the event of a head-on collision with autonomous vehicles. A very warm welcome to you, Dr. Lee. It is no astonishment that you have been given so many awards and honors, the prestigious Presidential Aquamarine Stripe Order of Service, as well as others. It is a privilege to have you with us today to take us through our session. I welcome you warmly to this event. In addition to Dr. Lee, I would also like to warmly welcome all our moderators from the 5 countries. From Kampala, we have Dr. Agre Lubikere. From Lagos, we have Dr. Otegbe Uthman. From Lusaka, we have Dr. Yannick Lombe. From Dar es Salaam, we have Dr. Baraka. From Nairobi, we have Dr. Christopher Opio, as well as Dr. Enoch Monge. In addition to this, we have numerous participants joining us from Sri Lanka as well as Mauritius. A very warm welcome to each and every one of you from these countries, as well as those who have joined us online. Welcome to this event. A few set of ground rules. After this, we will have Dr. Lee have his talk, followed by we will have 30 minutes of Q&A with Dr. Lee. As you have seen, it is very widely broadcast. So in order for hygiene, we will be given each moderator sessions 5 minutes or 3 questions. Sometimes a question may have more time, so we will restrict it to that, whichever happens first. And the order would be Uganda first, Dr. Agre. So you will be the first person, followed by Kenya, Tanzania, Nigeria, as well as Zambia. So the audience can put it 2 ways. You can reach out to your moderator with your questions, as well as you can put it on the QR code. We would request you to do both so that, if at all, this is a very small session, and I promise you it will be very enriching session. So in case your question is not taken up here, we can have it answered and given back to you. So kindly put it on the QR code as well as to your local moderator if you have any. With these ground rules, I hand over the podium to Dr. Lee for your session. Dr. Lee, over to you. Dr. Lee, can you hear me? You can start. You can share your screen and go ahead.
Do you see my present slide?
Yes, Dr. Lee, it is visible.
Okay.
Please go ahead.
Okay, thank you so much, Dr. Sabio, for your kind introduction to me. So, hello everyone. I'm Kang Hyun Lee from Yonsei University, Wonju College of Medicine. So today, I'm going to talk about optimizing outcomes in sepsis, synergy of the antimicrobials and immunomodulators. I'm emergency physician, also I'm a critical care physician in our hospital. Okay. Also, I have some occasionally travel to Tanzania, Uganda, and Uzbekistan, Sri Lanka for my EMS project. This photo was taken 3 weeks ago at the Makerere University in Uganda, Kampala, where I conducted a trauma resuscitation workshop there. Content of my presentation are as follow. First, I'd like to introduce the evolving landscape of sepsis, including burden of sepsis, evolving understanding of sepsis, and the clinical challenges in diagnosis and managing sepsis. Second, I'd like to talk about the role and importance of immunomodulatory agents. In sepsis, focus on the uristatin. And finally, I'd like to talk about the importance of educated source control of appropriate infectives and immunomodulators. Sepsis affect around 48.9 million people worldwide annually, with children under 5 years old accounting for 40% of all cases. 13.7 million people die each year by sepsis. The mortality rate is substantial, estimated at 22.5% and responsible for the roughly 19.7% of global deaths each year. The burden is especially very high in low and middle income countries where limited healthcare infrastructure often delay diagnosis and optimal management worsening outcomes. Sepsis is the large economic burden, approximately 0.33% of the country's gross economic output. As you know, the changing of the definition of sepsis is like this presentation. The understanding of sepsis definition has evolved over decades. Sepsis one at the 1991, sepsis 2 is 2001, and now the sepsis 3 criteria. The sepsis 3 definition universally used as a 2025 life-threatening organ dysfunction, the modern SOPA 2 score, caused by dysregulated host response to infection. The organ dysfunction is commonly assessed with the scoring system like SOPA. The term severe sepsis has been removed as any sepsis with organ dysfunction considered inherently severe. This picture shows the diagram representing the continuum between the infection and the occurrence of sepsis complication. As we know, the infection is the reaction of the host tissue and innate immune system to the invasion of the infectious agent. And sepsis is the aberrant or dysregulated host response leading to organ dysfunction, defined by SOPA score over 2. Septic shock is sepsis plus shock status, persisting hypertension requiring for the first to maintain mean arterial blood pressure over the 65 millimeter mercury and the serum lactate level more than 2 millimole per liter. And finally, it developed to the MODS. In MODS, the mortality was over the 50%. This picture visually presents phase and key immune process involved in inflammation and tissue repair. This image is divided into two main parts. Inflammatory phase, left side, the pink background side. This phase begins to tissue and cellular stress injury due to the pathogen entry by bacteria or virus or parasite or fungus. This phase begins with tissue and cellular stress injury due to the pathogen entry. So activation of the innate immune system occurs through recognition of pathogen-associated molecular pattern and damage-associated molecular pattern. This trigger recruitment of immune cells such as the monocyte, macrophage, and the activation of polymolecular stem cell activates the immune cell produced massive cytokine, chemokine, enzyme, and non-coding RNA to propagate the inflammatory response. The right side is the anti-inflammatory phase and tissue repair phase. Immune cell recruitment from bone marrow is regulated by chemokine CXCL12 and CXCR4. The mesenchymal stem cell migrate and secrete extracellular vesicle in the antimicrobial effect. This image illustrates immune response transition from initial injury and inflammation to resolution and tissue healing. The challenges, clinical challenges in diagnosis and managing sepsis. There are no single magic bullet treatment. The success hinges on timely, evidence-based supportive care, ongoing research into biomarker and risk stratification, and tailored therapy is needed. So, precision medicine approach, including immunomodulatory therapy, are under investigation and may offer future benefit. The right patient in sepsis, the sepsis patient often present with a non-specific symptom, such as dyspnea, weakness, altered mental status, pain, fever, and cough are common, but not universal. The classic signs like fever, rapid respiration rate, the high heart rate, confusion, clamminess, and hypertension may be present, but fever is only found in minority of sepsis cases. Some patients, especially older elderly patients, immunocompromised patients, may have a subtle presentation, especially with a altered mental status and general. And elevated inflammatory markers such as CRP, procalcitonin, WBC, and high and low platelet count and high lactate, the worst value are linked with a higher mortality. This is my case. Is 22 years old male visited our emergency department 12 years ago. He got a hypovolemic shock. We performed a massive transfusion. He's very hypovolemic state. The SIRS state, systemic inflammatory response status. Can you see my fingerprint on his chest wall? So it means the very hyperemic, very high SIRS system inflammatory response status. So this is my study. Our study in 1999 included the 11 SIRS patients and 10 non-SIRS patients and the 10 control groups who all had been admitted to our emergency room after multiple trauma. The result showed us that SIRS groups, you can see the TNF-alpha increased at 12 hours after admission and remained at high level until 5 days. This is the serum interleukin-6 in SIRS group increased in emergency room visit after injury and remains significantly in the high level until 1 day after trauma. So the relationship between the ISS and interleukin-6 is linear correlations. The p-value was the 0.009. Another one, I showed another one case. This 65-year-old female came to our emergency room with unstable pelvic bone fracture after traffic accident. We performed the angioembolization. Also, she got femur open fracture, and TB of multiple lung-warm, open lung-warm fracture. We control the breathing and the hemodynamically stabilized. You can see the large hematoma in pelvic cavity. After 10 days, she developed the multiple organ MODS status. Can you see the ectatic skin color on his whole body and the coagulopathy and the renal shutdown and developed to the ARDS. So how to prevent this multiple organ dysfunction syndrome after shocks? The mechanism of the MODS, you can see the shock state. It developed impaired the tissue perfusion, especially in GI mucosa. So it compromised the mucosal integrity and bacterial translocation from gastrointestinal to the intravascular. So they will make compromise the organ perfusion and microcirculatory failure. It developed multiple organ failure. In this mechanism, there are the precipitating events such as hypoxia, shock, trauma, infection, transplant rejection. That kind of insult increase the cytokine storm, pro-inflammatory cytokine, and also release of the abundance of the adhesion molecule ICAM and ERAM. And it is this adhesion molecule, leukocyte adhesion to endothelium, and that PMN cell migrate to the interstitium by the migration by endothelial damage site. So it will make perivascular intestinal edema and organ dysfunction. So this picture shows that this is the PMN cell migrate to the endothelium, and PMN cell migrate to the interstitium from the vascular spaces. Can you see this video? This is normal state. You can see the polymorph leukocyte. So this is the sepsis status. In sepsis, the leukocyte adhesion to the endothelium. After that, some leukocyte migrate to the interstitium, and at the interstitium, this PMN cell secretes the chemokine, chemotoxic material. So it makes interstitial edema. It aggravated perfusion impairment. So cytokine storm in sepsis is the serious problem. Excessive activation of immune cell and the release of the cytokine and chemokine, and the bursting of the pro-inflammatory cells such TNF-alpha, interleukin-1 beta, IFN, drive hyperinflammation. And also anti-inflammatory cytokine also upregulated, but unable to restore balance. It leads to tissue injury and acute lung injury. It makes multiple organ dysfunction syndrome. So the poor clinical outcome and increase the risk of death. So it's the potential involvement of cell death pathway like apoptosis, pyroptosis. The uridinostatin is the glycoprotein molecular weight is about 30 kilodalton pound in urine and blood. It is a uridinostatin urinary trypsin inhibitor. Is the broad spectrum protease inhibitor with the anti-inflammatory and immunomodulatory property. Uridinostatin attenuates the cells and preserve fetal function and number, and also it make anti-inflammatory function and hemostasis function so it improves the outcomes. The anti-inflammatory action of the uridinostatins are decrease utrophin infiltration and decrease elastase release and decrease pro-inflammatory cytokine, increase the anti-inflammatory cytokine such as interleukin-10. The uridinostatin downregulates stimulate the arachidonic acid metabolism, and also uridinostatin organ is protection under the various disease process, sepsis, ischemic perfusion injury, SARS, something like that. The indication of the unistatin treatment, sepsis, severe sepsis, ARDS, acute pancreatitis. Other potential indications are of the unistatin treatment are acute lung injury following severe hemorrhagic shock. As I showed in our research, in hemorrhagic shock, the bursting of the inflammatory cytokine, so it will make the SIRS and MODS. So, Stevens-Jones syndrome is the one of indication, possible potential indication, and after cardiopulmonary bypass and Kawasaki disease, something like this. There's so many evidence supporting unistatin effect in sepsis. I'd like to show the 6 journals. One of the journals is the meta-analysis of the 39 article involving 2,000, about 3,000 sepsis patients. So that they showed they systematically reviewed the efficacy and safety of unistatin in the treatment of sepsis. They showed a total 39 articles were included. The treatment of unistatin is reduced mortality, the risk rate to 0.52, and the MODS, decreased MODS, and the length of ICU stay, the mean difference was minus 5.42. Time to mechanical ventilation decreased, length of SASTA stay decreased, and they concluded that unistatin reduced sepsis case mortality, fatality rate, and improved the other related outcome. So they concluded that unistatin is effective in treatment of sepsis. Mortality reduction, all of the journal reduced the mortality. The mean mortality risk reduction was 0.52. The ICU stay reduction was minus 4.42, 5.42 days. MODS, the risk ratio decreased 0.3, and ICU length of stay decreased minus 5.42 days, and the Apache score decreased minus 4.59. Also, SOPA score decreased in treatment of unistatin. They concluded that unistatin reduced sepsis case fatality rate and improved other related outcomes. Another meta-analysis research paper showed when he did this. This is the 13 randomized clinical trial meta-analysis data. Also, unistatin treatment in sepsis, severe sepsis, septic shock. They included 1,358 patients. They showed 13 RCT and 2 prospective studies. It included 1,355 patients. So the result showed that unistatin significantly decreased the all-cause mortality. Odds ratio was 0.48. The Apache score reduced the incidence of MODS. Also, unistatin decreased the pro-inflammatory cytokine IL-6, TNF-alpha, increased the anti-inflammatory cytokine IL-10. So, this figure showed the relative odds ratio, the 0.48. They concluded that unistatin improved all cause of mortality and other related outcome in patients with sepsis or septic shock. Another study, this study, that retrospective study, indicated that unistatin reduced 28-day mortality in critical ill sepsis patients. They enrolled total 263 patients included in this study. The unistatin group showed significantly lower 28 days mortality rate than in the control groups. About 24% decreased the mortality. They concluded that statin was able to reduce the probability of death of 23.5%, very high. This table showed the mortality reduction in statin treatment groups. Another study showed statin combined with the continuous blood purification therapy significantly reduced inflammatory marker such as CRP, IL-1 beta 1,6, IL-8, TNF-alpha, procalcitonin. Mortality compared to the control, they suggest the synergic immunomodulator effect in sepsis management by statin. They ignored 28 RCT study and 6 retrospective studies. So the result, the mortality would decrease, the odds ratio was 0.330 in statin groups. They concluded that statin combined with continuous blood purification significantly reduced the inflammatory marker and mortality in sepsis patients. Another one study pediatric cases in children with septic shock. Statin combined with standard therapy improved the clinical outcome, decreased the inflammatory markers. They would like to investigate the effect of statin on therapeutic outcome inflammatory marker in children with septic shock. Total 117 children with septic shock admitted in this study. The results show that therapeutic effect and level of inflammatory marker were assessed before and after treatment using double antibody standard test. The outcome was significantly better in statin treatment group compared to the control. So after 7 days of treatment, the experimental group showed a significantly low level of CD64, PCT, procalcitonin, CRP, neutrophil to lymphocyte ratio, and serum alpha hydroxybutyrate dehydrogenase compared to the control groups. Statin enhanced the therapeutic efficacy in children with septic shock by reducing level of associated inflammatory marker and promoting recoveries. Now, this table shows the result of that. Decrease the duration of the mechanical ventilation, length of hospital day, and length of ICU stay. There are no differences of adverse drug reaction in the two groups. Another one study IV statin treatment in severe sepsis cases. It's multi-center randomized control study. They would like to show the effect of statin on 28 days all-cause mortality double-blind trial patient with severe sepsis in 7 Indian hospitals. It was published at 2014 Intensive Care Medicine. They showed they gave treated statin 200,000 international units for 5 days. Compared with the statin group and placebo groups. The 28 days all-cause mortality was 7.3% in statin group, only 4 deaths in statin group. In placebo groups, mortality was 20.3%. So it's so big difference in mortality. So low instance of new onset failure, the more ventilate-free days in statin groups. They concluded that the IV administration of statin reduces mortality in patients with severe sepsis. This is the diagram of their study. They compared the two groups, treatment of statin group and the placebo groups. You can see the 28 days of all-cause mortality in placebo was the 20.3% mortality. Statin was 7.3% mortality. And also, in statin group, treatment group decreased the ventilation-free day and the length of stay in ICU. They concluded that IV administration statin reduced mortality in patients with severe sepsis. So you can see the Kaplan-Meier analysis of the probability of survival. So big differences between the statin group and the placebo groups. In conclusion, in statin treatment in sepsis, statin significantly low all-cause mortality in patients with sepsis or septic shock. Also, unistatin is associated with reduction in severe Apache score and the incidence of MODS, also length of ICU stay. Also, unistatin consistently lowered inflammatory cytokine, pro-inflammatory cytokine, and as combination therapy with unistatin and extracorporeal blood purification further decrease inflammation and improve survival rate in severe sepsis. So I'd like to introduce the unistatin used in ARDS cases. I'd like to introduce two meta-analysis study. One meta-analysis study was the 29 RCT case. They included 1,725 patients. They found that the unistatin significantly improved the oxygenation index, reduced ICU mortality, the relative risk of 0.48, and shortened the ICU stay. They included 29 RCT cases. Unistatin significantly decreased the ICU mortality. 28-day mortality was not significant effect. Also, length of stay in unistatin group significantly lower than the control groups. So they concluded that the unistatin seems to be effective for acute lung injury and the ARDS. Another evidence in unistatin effect using ARDS, it randomized trial and the prospective study. They suggest that unistatin is the more effective, improving lung function index and reduced inflammatory marker and shortened the ventilator therapies. They showed treated with unistatin for 14 consecutive days. The results showed that arterial blood lactate in significantly low in unistatin group. Oxygen uptake increased in unistatin treatment group. The duration of ventilator treatment is significantly shorter in unistatin treatment groups. Also, pro-inflammatory cytokine is significantly low in unistatin group. They concluded that the unistatin application combined with the mechanical ventilation ARDS patient is great significance improving the oxygen delivery, consumption balance of the body, and increase the lung function and reduce the inflammatory and stress response. So this figure showed the differences. They compared the before intervention. They checked the pro-inflammatory cytokine, TNF-alpha, interleukin, something like that. So they compared the before intervention 1 week after unistatin treatment, 4 weeks after unistatin treatment. In unistatin treatment group, the decreased the pro-inflammatory cytokine. Also, they compared the ventilated spot and the hospital stay times. It decreased the ventilated spot in unistatin group and the hospital stay in unistatin group. So, while direct evidence of ARDS is more limited compared to sepsis, the unistatin has been used to modulate the severe inflammatory response underlying ARDS, contributing to improvement of organ function and the survival, particularly when associated with sepsis-induced ARDS, specific the inflammatory status. Another effect of unistatin I'd like to introduce is in my research report. So we published the unistatin treatment effect in hemorrhagic shock to the Journal of Korean Medical Science in 2010. We would like to show the anti-inflammatory effect of unistatin in trauma patients with the hemorrhagic shock patients. We investigated the use of unistatin associated with suppression of the PMN, elastase, and pro-inflammatory cytokines such as TNF-alpha, IL-6, and we would like to know the effect on the prognosis of patients with traumatic hemorrhagic shock by treatment of unistatin. We know the 11 patients visited ED trauma, hemorrhagic shock, and this 11 patients were randomly selected 300,000 unit of urinary treatment. We measured the PMN, elastase, and the pro-inflammatory cytokines. We compared the SIRS score and the MODS score, Apache the 3 score at the time. So our result, the serum PMN polymorphonucleoside elastase levels in urinary group was lower than control groups. And on second hospital day, serum TNF-alpha IL-6 in urinary group decreased 24 hours after admission. This is our protocol of our research. So you can see the urinary treatment, the black is urinary treatment groups level of serum TNF-alpha. And the white bar is the control group. So you can see the decreased TNF-alpha by treatment of urinary. Also, interleukin-6 also decreased in the first visit time, the urinary IL-6 was increased in the control group, but after treatment with urinary, the decreasing of the IL-6 was decreased in IL-6 rapidly. So we concluded that this suggests that urinary treatment could decrease the serum PMNE level in trauma patients with hemorrhagic shock at 45 hours after treatment. The adverse effect of reaction of the urinary there are no serious adverse effects, just rash, itching, and the pain on the site of injection, nausea, diarrhea, and very rare elevation of transaminase and neutropenia and anaphylactic shock is very rare. So the safety for pregnant and children is not determined. There are no drug interaction. So one of this paper showed the safety of the urinary. They evaluated the post-marketing surveillance of 11,252 patients in China. They would like to investigate the real-world safety of urinary in China. So it's a multi-center study retrospectively analyzed the data between the August 2014 to June 2017. They checked the adverse drug reaction and the adverse drug event in urinary treatment groups. But adverse drug reaction or adverse drug event rate of urinary injection was 0.98%, very low. So in most cases of adverse drug reaction and drug event, gradually disappeared, recovered after drug withdrawal. So I'd like to talk about the importance of educate source control of anti-infective and immunomodulators. Educate source control is very important. Also, appropriate anti-infective therapy and the immunomodulator are all critical components in management of sepsis to improve the patient outcome. I'd like to actually, this slide provided by Dr. Sapio. The source control is the cornerstone of sepsis management. So the impact of the no source control require additional intervention. It increased about around 2 times higher mortality. And the timely, appropriate antimicrobial therapy and surgical intervention, source control is very important. Also, polymyxin B, especially gram-negative infection in sepsis management, polymyxin B is also very important antibiotic, especially antibiotic-resistant bacteria with very high mortality groups. It's very important, the treatment, the amphotericin B. Also, liposomal amphotericin B in invasive fungal infection, it's also very important treatment in sepsis and severe sepsis. The empiric fungal treatment is febrile neutropenia in disseminated Candida and mucormycosis, aspergillosis, leishmaniasis, cryptococcosis, histoplasmosis. In these cases, especially the patient admitted in over the 7 day, the neutropenic infection is the liposomal amputation B needed in to eradication of the invasive fungal infection. Okay, this slide show the immunostatin market share. So there are very rapidly increasing of the immunostatin using in the global market. The global use of immunostatin is growing significantly with the projected annual growth rate of the 15.74%. It's very highly rapidly developing our immunostatin using in global market. Okay, I'd like to give the take-home message in immunostatin treatment. Immunostatin reduce the cytokine storm, especially patients with sepsis, hemorrhagic shock, acute pancreatitis. It may decrease the mortality, but immunostatin treatment decreases the mortality and severity in sepsis, septic shock, especially sepsis. The right treatment to start immunostatin treatment, I think there are no gold standard. I introduced my research is you show the cytokine storm in the very early phase, very rapidly increasing. So I would like to recommend immunostatin treatment as soon as possible in sepsis, the early sepsis stages. So also the duration and the optimal dose of immunostatin, there are no gold standards. There are some diverse duration and optimal dosage in immunostatin treatment, from 300,000 to 1 million international unit. Also, the importance of adequate source control and appropriate infective treatment is also very important with the polymyxin B and the liposomal amphotericin B. Also, there are no serious complications by using immunostatin. Okay, thank you so much for your attention.
Thank you, Dr. Lee, for that comprehensive, very detailed session. It was very helpful as well as practical. Right now, I would like to open the session for Q&A. And as we had discussed initially, I would start with Dr. Agre, Uganda.
Good evening, everyone. Thank you so much, Professor Lee, for the presentation, and a very good morning to you. I know it's already 1 o'clock in your side of the world. We are very grateful that you've been very patient with us, but also you've been kind enough to share your knowledge and experience in the use of this novel drug. And also thank you for visiting and training our citizens in Uganda. The questions I have is probably 1 or 2. In the experience of vulnerable population, pregnant mothers have come across articles where they've had to use, based on the pharmacokinetics of immunostatin, in the use of preeclampsia in pregnant mothers. There are case studies and case reports that have been reported. I would love if you can share with us what has been your experience, because where I work, we have hypertensive disorders of pregnancy as being one of the causes of maternal mortality in my country. But if you look at the pathophysiology, it's all inflammatory cytokine storm with endovascular damage leading to leakness, and then there is a lot of organ dysfunction. Then the other population would be, we are a country which is about to start organ transplant. What has been your experience in this vulnerable group of population where there's solid organ transplant or where there's stem cell transplant? And then there is also the issue of, if I get a patient who already has MODS, what would be my initial loading dose?
Yeah, hi, Dr. Agre. We'll take one question after another. Is that okay? Because otherwise, it will become too continuous. Can we answer the first one and then go on to your second, if that is okay with you?
Thank you so much. That's very okay with me.
Sure. Dr. Lee, over to you.
Okay, the hypertensive emergency in pregnant women. I'm not an OBGYN physician. I don't have any kind of experience about that. But there are no the evidence. Unistatin. Actually, I have no experience in OBGYN hypertension patient, but in hypertensive in pregnant patient, in that case also very high bursting of the pro-inflammatory cytokine. So I think unistatin will decrease the cytokine bursting, but I don't know. I cannot guarantee the fetal effect on the fetus by the unistatin treatment. So do you have any experience about that in here?
Sorry, Dr. Lee. Who was that for?
As a country, we don't have any experience, but most of the information we have is publication based on other countries with good outcome, but the numbers are very small to have a big impact and make a comment.
Thank you, Dr. Agre. Maybe you can go on to your next question.
Okay, my last question will be, in the event that I get a patient who has already passed the point of sepsis and is having MODS, what would be my ideal loading dose so that I de-escalate as fast as possible? Because mortality is based on the number of organs and also the time. So sometimes patients come late or they are referred from other units when they either have a lot of organ dysfunction. And at that point, you need to escalate. What would be the most ideal dose to load such a patient who has already signs of MODS as a way to reverse the inflammatory cytokine storm?
Dr. Lee, to respond to that? In MOD?
Your second question was the treatment, not the treatment in the organ transplantation patient, right? Yeah, I think the unistatin will be effective in organ transplantation patient. So also in organ transplanted patient have increased the pro-inflammatory the cytokine. So I think during the cardiopulmonary bypass surgery at that time, the unistatin, some hospital used the routine treatment of unistatin during the cardiopulmonary bypass surgery.
Thank you, Dr. Lee. Dr. Agre, any last question do you have?
The last dose was just about escalation dosing in MODS.
In MODS, yes. Dr. Lee, usage of unistatin in MODS cases which I've already set in multiple organ dysfunction.
MODS. Yeah. The sepsis-induced MODS or hemorrhagic shock-induced MODS is very useful. The treatment of unistatin is very useful in that cases, I think.
Okay. Thank you, Dr. Lee. Thank you, Dr. Agre. So that is our 5 minutes for Uganda. Thank you for your questions. I'll move on to Kenya currently. Over to you, Dr. Enoch.
Thank you very much for that very stimulating presentation, Professor Lee. Just a few basic concerns. You mentioned timing of therapy. Are there any studies that compare early initiation versus initiation beyond 48 hours? And could you mention something about optimal duration of treatment? Why 5 days? Could it be less? Could it be more? Secondly, in terms of the immunomodulatory properties, how does this compare to corticosteroid?
Dr. Enoch, we'll take one question at a time, otherwise it may get overburdened. So we'll answer the first question. Over to you, Doctor.
Yeah, I think the initiation time is the early, as soon as possible. The early treatment is the effective, but they are now no gold standard. The mostly in when the diagnosis of sepsis, septic shock, at that time, the mostly using the urinastatin. But as I showed my data, you showed the results showed that the early stage, very rapidly increasing of cytokine, pro-inflammatory cytokine. So the peak level of the cytokine will be sustained around 5 days. So the duration of treatment is not there are no standardized duration, but mostly 5 days. Some papers show the 7 day treatment. Some papers show the 3 day treatment. So we need the more data to optimal duration of treatment of urinastatin, I think.
How does this treatment compare? How does urinastatin compare with corticosteroids? And can you use combination therapy? And are there other immunomodulatory agents that can be co-medications in immunomodulation?
Yeah, steroid is one of the options to treatment of the in sepsis, severe sepsis cases. So I think, yeah, I didn't show the combination with the urinastatin and steroid more increased the survival than urinastatin monotherapy or steroid monotherapy. So by pharmacokinetics, I think, yeah, we if the patient need a steroid, yeah, it's okay to give the steroid and urinastatin treatment, I think.
In terms of precision, in terms of precision medicine, you are elaborating lots of cytokines apart from TNF alpha, interleukin 6, interleukin 10. Are there other targets you can derive combination uses with urinastatin? Can you combine?
Yeah, if need the indication of the treatment, it's no problem. The combination of the steroid and urinastatin.
Okay. Now, considering that neutropenia is one of the potential adverse effects in patients with neutropenic sepsis, sepsis with neutropenia, would you be cautious to use this agent?
Yeah, one of the neutropenic sepsis, we should think about another option of treatment, the amputation B or antimicrobial agent, and also, yeah, you should think about the choice of the amputation B.
Okay. We see quite often patients with severe malaria, and we think there is inflammatory response to malaria. Is there a role of urinastatin in this kind of patient?
Yeah, actually, I don't have any experience in malaria treatment. In Korea, very few malaria patients in here. So theologically, uh, it's one of the choice to treatment of immunostatin in malaria cases. Even in malaria cases, the cytokine bursting will be happening in malaria cases. Dr. Sabir, do you have any information about it?
Yeah, hi, Dr. Lee. So when we look at the pathway, as you had said in the initial part of it, the central developments in sepsis, what prompted sepsis 3 was the understanding that it is the response to the infection which is causing problems as compared to the infection per se. And as you had pointed out in your infection control slide, infection control takes its role, and it's the downstream cascading and dysregulation of the immune system which is causing SIRS. When we apply this principle into looking at the clinical picture of the patient, either through a SOFA score or monitoring organ dysfunction, that is where the clinical utility of ulinastatin as an add-on treatment comes into the picture. So when we are looking, and this is a molecule which is now being explored, there are so many studies which look at modulating the immune system. So it is very important that we look at where the studies are, what the data has proven. We have very clear indication in sepsis. Wherever there is a damage associated pattern or a pathogen associated pattern happens, and we have an excess of inflammatory cytokines, there are different markers for it. If we have an IL-6, fantastic. But sometimes we may only have a CRP or a PCT. Even that, you can identify that the patient is going in for severe sepsis. In that, along with your anti-infective treatment, be it antibacterial, anti-malarial, antiviral, anti-tubercular, just make sure there are no underlying immune suppressions, because the cross interactions with that, I think someone had asked a question on in an immunosuppressed patient, can you give? There is no data available on this, because in an immune suppressed patient, the immune response itself is very different. So modulating that would be a different story. Here, my treatment goal would first be get the immune system back online. Try to get a polygraph, GM-CSF injection, if that is possible. Are there any immunosuppressive agents that is going on? Central lines, TPN, those kind of things would be first goals to get the immunity back online and then see what the immune dysfunction is. So it's not a linear answer, because a lot of this is path breaking, and there is so much research coming in that coming in from pioneers like Dr. Lee also. They are so varied. Since we look at this as a molecule, we are able to guide in terms of that. But as per the data, if it is very from sepsis, ARDS, acute lung injury, as well as other indications what Dr. Lee had mentioned, early initiation of it is very helpful. So sorry for going a little broad, because it's the context and the concept that helps you use it in treatment. I hope, Dr. Enoch, that gives you a context for your question, if may not completely answer it. So we'll move from Kenya to Tanzania now. Dr. Baraka? Yeah.
Thank you very much indeed for the presentation, Professor Lee. Yeah, it's on. It's on, yeah. Right. Thank you very much, Professor Lee, for such an insightful presentation that we have received. I have two questions for you, Professor Lee. The first one is based on the sepsis burden, which was the first part of your presentation, and the second question is based on the experience with ulinastatin management of patients with sepsis. So with reference to one of the biggest hospitals here in Tanzania, the prevalence of sepsis in our patient is up to 64% of all the cases. And among these 64%, up to 42% of those patients die. And sepsis contributes to up to 23% of total mortality in our ICU setting. So my question to you, Professor Lee, was how is the burden of sepsis in Korea? Like, how is the prevalence of sepsis in Korea, and what might be the associated factors? In just to compare with us and to see how are we going with respect to Korea, which is one among the developed countries, especially in medicine. So that is my first question, the prevalence of sepsis in Korea and the associated factors. And the second question will be on the microbial resistance.
Dr. Baraka, can we take the first question and then go
Yes.
to the second? Yeah.
Yes, please. Thank you.
The prevalence of sepsis in South Korea is increasing because of the aging process very rapid in Korea. So Korea is the aged society. So the aged society, aged people have the mostly immunocompromised, and also they have so many comorbidity. So the infection, the pneumonia, the sepsis, UTI, the most of the infectious disease increasing at this time. So I do not actually I don't know the accurate percent, but the prevalence is very rapidly increasing at this time.
Thank you very much, Professor. And so the second question also has been answered, the associated factors, age, comorbidities, etc. And how is the pattern of microbial resistance in Korea? Because here in Tanzania, it's very high. How is it there?
Yeah. Microbial resistance also very rapidly increasing. So multi-drug resistance in here. So the hospital very focused on the clean hand prevention of the in hospital infection. I think it's very big issue at this time. Yeah. Also, the prevalence of in hospital infection are increasing.
Yeah. Thank you very much, Professor. And with respect to the use of ulanestatine here in Tanzania, especially in my hospital, we have been using it in all processes which involve inflammation. For example, we've been using it in patients with severe malaria. We have been using it in patients with extensive burn injury, with acute liver failure. And in all the cases, the results have been very spectacular. The thing is, we're asking ourselves, and what is your recommendation? Can we put ulanestatine as one among the standard treatment of sepsis together with antibiotics since day one? What's your recommendation, Prof?
Yeah. Do you work in Wimbili Hospital?
Yes, please.
Okay. Upangila or Upanga?
Upanga. You came to visit us.
Yeah. 2 weeks ago I visited. Yeah.
Yes.
Yeah. I think the sepsis, the SARS, severe burn, the massive hemorrhage shock, tissue injury, all of the hyperinflammatory states that I think that ulanestatine effective in that cases, so decreasing the cytokine storm and decreasing the inflammatory process. Definitely also use the antibiotics in cases, in sepsis cases, infection cases, I think. But at this time, ulanestatine treatment not noted in sepsis treatment guidelines. But I showed today I introduced so many RCT study. They are effective or high. So I think the guideline will be changed in the future.
Yeah, thank you, Prof. And lastly, do you frequently use ulanestatine in treating your patient?
Yeah.
You use it, and you have good results. Thank you.
Yeah.
Thank you, Dr. Baraka. Over to Nigeria, Dr. Otegbe.
Thank you, everyone. Thanks for allowing me. Well, I have 2 questions there. The first question is, why is enteral feeding encouraged in sepsis? despite the GI compromise that arises with it. Can I go to the second one?
We'll take the first question and then we'll come to the second one, if that is okay, Doc.
Do you mean
All
that
right.
the side effect of urostatin, of GI side effect?
No. It's looking at why enteral feeding is encouraged in sepsis despite the GI compromise. Looking at gut dysbiosis.
Yeah. That's one of the one of the region why developed in sepsis in massive hemorrhagic shocks. It's GI mucosa, the hyperperfusion and in GI mucosa. So it will be a translocation of the GI, the E. coli, some bacteria from GI tract to the intravascular. So it will make increasing the MODS by severe hemorrhagic shock. Did it answer for you?
Yeah, Doc.
Okay.
Dr. Otekbai, do you have any other
All right.
questions?
Now, the second question. In cancer patients, there are times you see sepsis in cancer patients. And does it think that urostatin can it be beneficial in sepsis in such patients, whether nosocomial or not?
Yeah, in sepsis, in cancer patients, it's very easy to develop the sepsis because of the immunocompromised status in cancer patients. So it's also they got many catheter, many injection. So it's very the most cancer died by sepsis, right? UTI, pneumonia, like that. So I think the urostatin will be helpful to improve the sepsis, improve the sepsis mortality.
All right. Do we have to reduce the dosage in renal compromised patients?
I think we can use the but I don't know exactly my I don't have many experience about the treatment in renal compromised patient. Dr. Sabir, do you have any idea about
you need not reduce it, Doc. You need not reduce it in renal failure or hepatic failure. No need for dose reduction.
You don't need the dose reduction.
That makes it up.
Dr. Otekbai, any further questions?
Oh, I have several questions.
Yeah, please go ahead.
All right. Well, Wang et al. In their meta-analysis reported some adverse effects of urostatin. What do you think about it? Do you think we should be worried about using urostatin in patients who are very sick?
I think the birth effect of urostatin is not so serious. So, I introduced introduced the side effect cases by using the urostatin. The birth effect is very low, 0.98%. The most of the birth effect is not so serious. The skin reaction or something like that, the nausea, vomiting.
All right. My last question. Okay. Another question. In patients with acute kidney injury or chronic kidney injury, do you think urostatin can be helpful in managing sepsis in them?
Yeah, sepsis or like SARS infection will be compromised the renal function, ischemia and the perfusion injury or inflammatory change in the renal cell. So, or sepsis, and SARS increase the renal insult of renal injury. So the unistatin treatment in sepsis, in SARS, in massive hemorrhagic shock status, I think unistatin will prevent of the acute kidney injuries, I think.
All right, thank you. Okay, I have a question now. Does reduction in PNME, that's one of the sepsis, the inflammatory markers you spoke about, if ulinastatin reduces it, do you think that's going to translate to improved survival, or will it improve the prognosis of the patient?
Yeah, I think so. Yeah. But in my cases, that we just ignored the 11 cases, we could not figure out the mortality, morbidity by decreasing the PMNE activation. So, I believe unistatin definitely decreasing the PMNE activation.
Thank you, Dr. Otegbai.
Thank you.
Thank you for your questions.
Thank you, that's all.
Thank you. Now we'll move on to the last country, Zambia. Dr. Yannick.
Thank you very much, Professor Lee, for that important presentation. So in Zambia, I think we have three more questions, but I think a couple of them have been answered already. So I'll start with the first one. The first one is on drug interactions. So what, especially with antimicrobials, what drugs do you think what other things do you think we should be looking out for in terms of the interaction with ulinastatin, with antimicrobials?
I could not find out any drug interaction with the ulinastatin and the antibiotics. I think there are no drug interaction between the antibiotics and ulinastatin. Dr. Sabir, do you have any opinion about that?
I agree with you, Doctor. Ulinastatin is a naturally occurring compound manufactured by the liver itself, and it has a very short T-half. That is one of the reasons why we give it there. Because of these two factors, the safety footprint of the molecule is very, very good. There was the data that Dr. Lee had shown on 12,000 Chinese patients, and there was only one serious adverse event, which was mild elevation of liver enzymes, which transiently came down. Other than that, there were 11 adverse events in real-world consecutive 12,000 Chinese patients in using ulinastatin. So no drug-to-drug interactions documented, or the safety footprint in the real-world safety data. This was proposed.
Thank you very much for that. The second one is on the presentation. I think you talked of the meta-analysis. So there's a question on the patients that were immunocompromised, especially HIV and some of the patients who are on chemotherapy. So the question there is, what was their presentation? Okay, in the meta-analysis, what was their presentation? HIV patients and also the patients that were on chemotherapy and also on the immunosuppressant drugs. What were the presentation?
In their meta-analysis data, they did not show the disease entity. Just they ignored the sepsis and septic shock, severe sepsis, septic shock. So I did not find out any infection sources, HIV, malaria, something like this. Do you have any, Dr. Sabir, do you have any information about that?
Yes, Dr. Lee. So what is happening is that when these studies are done, they have a definition of sepsis. Now, we need to visit back on the condition. Sepsis can be done by so many infectious pathologies. And once a person is diagnosed to have sepsis, the infection is considered as part of that. And once you identify the cascade, so it is very important, understanding to use ulinastatin requires you to identify one central thing, which is the dysregulated immune response in sepsis. It came out during the COVID crisis. Person with COVID, we are managing it, and then all of a sudden he starts turning bad. The lung starts going for a toss, various organs starts failing. It's like having a hole in your house roof, but your TV is getting flooded by water, your paintings are getting damaged. So we are trying to fix, rather than fixing the hole in the house, you're spending time repairing all the other things. That is what happens in sepsis. And central to understanding that is using sepsis. When you get an infectious person, again, it is also necessary to understand if a person is immunocompromised and then having an immune dysfunction, then you need to take a step-by-step basis. We look at the neutrophil count. In a person who's neutropenic, the first step is to bring the count up and then see what happens. That is central in dealing with neutropenic sepsis, especially in an organ transplant setting or cancer setting where it's immunocompromised. That is foundation for neutrophil. Once you give your GM-CSF and the neutrophil comes up, then you look at where the markers are going, or you look at organ dysfunction. So that kind of patients are highly volatile, and we need to monitor them on basically 2-hourly, 3-hourly basis. But if you're seeing your inflammation is going up, each organ is failing one after another, the SOFA score is now going up, you start getting organ dysfunctions, ventilator oxygen requirement starts going up, urine output starts coming down, your liver is showing signs of failure, that is a good time to start ulinostat. And I am getting a lot of questions online as well. The safety of this, when usually you are giving a molecule that is present inherently normally made in your body, the safety footprint of it is good. I'll give you an example of insulin. Insulin is associated with adverse events because of impurities part mostly, but it's mostly inherent in your body. So in a similar manner, your ulinostatin is also made in your body, and because of that, and because of the short T-half, the side effect profile is very less. Sepsis, due to any etiology, that is central in sepsis 3. Sepsis 3 talks about managing sepsis as an entity. It does not speak about managing sepsis in bacteria, malaria, because sepsis is a pathway. That was the difference between sepsis 2 and sepsis 3. And in understanding the immune dysfunction that is causing the problem is key in starting ulinostatin. So whichever pathway it comes, it could be a PAMP, it could be a DAMP. PAMP is pathogen associated patterns and DAMP is damage associated patterns. Both will trigger a sepsis sort of image because of the immune dysfunction and the cytokine storm. So I hope that simplifies things, not complicates. Because sometimes, sepsis, we get lost in the intricacies that sometimes we miss to see the common pathway that unifies.
Yeah, there are so many sources of infection, so many bacteria, fungus, virus. So the process to develop sepsis, septic shock, is the same immunological pathway. So ulinostatin to block that immunology pathway. So yeah.
Okay, thank you. Just lastly, the last question. I just want to focus on the dosing and also the duration. So on the dosing, I want to ask, can you give ulinostatin in children? And what could be the dose and the duration? And also in elderly patients, do you need to adjust the dose or what?
Yeah, we do not dosage adjust in geriatric in people. So yeah, but it depends on the clinical situation, the acute pancreatitis, sepsis, something like that. It depends on the disease entity, not the age or not body condition.
And in children, can we give it?
I'm sorry?
Can we give it in
a pediatric patient?
Yes.
Yeah, in pediatric cases, yeah, we dosage adjust, yeah, by a kilogram, body weight. Like
what age can we start? At what age can we start from?
depends on the clinical situation. So yeah, in sepsis usually 100,000 unit with the normal saline 100 milliliter. The IV, we keep IV, and in pediatric cases, I don't know exactly the dosage, but we should adjust the dosage. In the cavity vascular surgery, the 5,000 units per kg in used in another research paper. Do you have any, Dr. Sabir, do you have any information about that?
Yes, Dr. Lee. So, as per the drug label, it provides that ulinastatin should be administered. Just a moment. Ulinastatin should be administered in caution with children. It is a safety dose for children is not yet determined for ulinastatin. This is what the central study data in our label also says. But there was a paper that came out in 2025 where they looked at 98 children from 6 to 12 years of age with septic shock, which was done from April 2023 to 24. Here, ulinastatin, 20,000 units per kg. This was the dose that was mentioned in the study. 20,000 units per kg in 50 ml 5% glucose was given 1 hour twice daily for septic shock management. And in this, there was good effect. The total effectiveness rate was 97.96% with an adverse reaction of 2, which was diarrhea. That was all that was seen in these patients. So yes, the real world data in 2025, there was a paper, Gao S et al. And this was the data that came out of it. In terms of efficacy, it was there. It reduced the CD64 count, the procalcitonin level, the CRP, the neutrophil NLR, neutrophil to lymphocyte ratio, and serum alpha hydroxybutyrate dehydrogenase as well. And as I said, the effectivity rate was 97.6% with this side effect profile. So I hope that answers your question, Doctor.
Okay, no, thank you. I think those are the questions we had.
Thank you, Dr. Yannick. I have quite a lot of questions that have come from online. I would just ask Dr. Lee a couple of them. We would not be able to answer all of this completely on this, but we will ensure that they are answered for you. If you are in a place with your local moderator, please discuss this and we will also get you the information. So a couple of them I would take for Dr. Lee if possible. Dr. Lee, how would you differentiate with using steroid in these patients? Can we use steroid in sepsis, or is ulinastatin a better option? But that was one of the questions that came in.
Actually, the steroid is not common used. Yeah, the ulinastatin is the common used. Yeah.
Okay. All right. Another one that was used is, do you, in your personal practice, what is the range of procalcitonin or C-reactive protein that you would advise in the setting of low income setting? How can you use that to decide when to start ulinastatin?
Yeah, it's the CRP and procalcitonin is the one of the valuable biomarker to checking the severity and the initiation of the ulinastatin and antibiotics. So yeah, procalcitonin, yeah, it's very useful biomarker in ED or in OPD, procalcitonin and CRP.
Okay. All right. So I think we have overextended our time. At this point, I would like to, thank all the participants. And also I would like to mention here that BSV strongly encourages the use of a product in line with the recommended instructions on the prescribing information. And thank you, Dr. Lee, for taking us through, the new age of sepsis 2 to 3. understanding the key pathways and how, the videos, the part of it, the leukocyte coming out, that was extremely, what we see puts an imprint on us. The importance of that, the importance of identifying it early and starting ulinastatin early to get the desired response. Thank you for taking us through the data so eloquently. And thank you, Dr. Lee, for patiently addressing all these queries. And a huge thank you for all the moderators, all the participants who patiently have been with us online as well as physically present in the venues. A heartfelt thanks to you. And thank you again, Dr. Lee. It's always a pleasure having you have a talk with us. It was an absolutely great session. And have a great day, everyone. Thank you.
Thank you so much.
Thank you, Dr. Lee. Thank you, Dr. Savio. And thanks to all the moderators. I just want to call out all the respected moderators who have been actively engaged in terms of asking those pertinent questions. Dr. Agre Joseph, always a pleasure, sir, from Uganda. Dr. Baraka, once again, for those insightful questions from Tanzania. Dr. Yannick Lombe from Zambia, again, for your valuable work and inspiration. Dr. Otegbaye Ajbola from Nigeria, I'll be meeting you right away, sir. Sincere gratitude on behalf of BSB. And both our moderator, Dr. Christopher Opio and Enoch Omange from Kenya, for your valuable presence. We really, really got inspired by your presence and the questions to Dr. Lee. So, Dr. Lee, it's almost 2:30 a.m. in the morning. It's almost, for us, it's dinner time. For you, maybe you are fast approaching the breakfast time. Really, truly grateful for that time and your presence and your involvement, sir. We would like to, I think in BSV, this is a continuous process, promoting good science, working with you all, esteemed doctors across the globe. In fact, other than these locations, we had more than 300 doctors who are present in various countries joining online from their offices. We wanted to express our sincere gratitude. And finally, last but not the least, our internal team, the core team from head office, including Dr. Savio, Dr. Kaushik, Shraddha from my team, along with Mrinal, putting up this wonderful show put together. And all our country leaders, Kapil is there, I'm looking at him at the screen, Amar and Shivendra is over there, and our cluster head, Mr. Chandrasekhar, is here personally in Nigeria. For that matter, Deepak and his team over there in Uganda, along with Dr. Agre, and Sai and his colleagues over there. I think Rajiv, I missed to mention you, Rajiv from Zambia. So these are all the leaders who have been passionate about promoting this good science. I mean, the program won't be ending without heartfully congratulating them, thanking them. Thank you, sir, for your presence. And finally, I think this is second half of the story where our local moderators, wherever the questions which are not answered, or for that matter, there is a case study that they will be doing a physical program over there. In those respective locations. I think Dr. Savio and Dr. Lee, with all your permission, we can go offline, and then the local moderators, along with the help of country managers, will take over from here, over there. Yeah. Thank you, team, once again. Have a good morning, sir. Dr. Lee, looking forward to work with you.
Have a good evening, Dr. Lee. Good day.
Thank you so much.
Thanks,
Thank
you.
Bye.
Thank you so much.
Yeah.
Thank you so much, guys.
Yeah.
Thank you.